Hello wonderful students, myself Dr. Maddineni Srinivas, your dermatology faculty from Bharat. So in this video we are going to cover the sexually transmitted disorders in the form of high yield, very important, rapid revision, quick revision, last minute revision, one liner point of view. So whatever may be the source you are following to read the dermatology, this video is going to help you for the quick recap of the sexually transmitted diseases, in which we are going to cover the anogenital warts, molluscum contagiosum, urethritis and the genital ulcer disease. So let us begin our discussion with the anogenital warts. So I hope all of you do remember that anogenital warts, they are associated with human papillomavirus infection, HPV, and there are so many types, 150 to 200 types of HPVs. So 6 and 11 are associated with low risk and 16 and 18 are associated with high risk. High risk simply means that the possibility of malignancy is very high with these strains. So it is skin to skin contact during the sexual activity which is going to produce the lesions. And remember students, the anogenital warts, they are also called as condyloma acuminata. Remember one more important term which is very close to the condyloma acuminata, it is condyloma lata, which is the manifestation which we see in the secondary syphilis. Okay, very important point. And clinically the lesions are going to be flesh colored cauliflower like growths which will have a rough surface or verrucous surface, which we call it as, in the anogenital area, and these are typically painless and maybe slight itching or discomfort may be there, but otherwise it is a completely normal condition which patient will not feel anything apart from some growths, and it is mainly a diagnosis of clinical features. So clinically we can diagnose this condition, and if we have to confirm it, we can do a biopsy where we are going to see the vacuolated keratinocytes which are called as coilocytes. And management is going to be first counseling and the HPV vaccination discussion should be done. Okay, later coming to the treatment part, remember podophyllin, imiquimod, both these can be used safely in a non-pregnant individual. So woman non-pregnant, if the patient is mentioned in the question, then you can mark it as podophyllin or imiquimod. But if the examiner gives it that it is a pregnant woman, then you have to choose cryotherapy, or we can also use trichloroacetic acid, but cryotherapy where we are going to use liquid nitrogen at minus 196 degrees Celsius to uh, cool the tissues and kill the HPV. That is the preferred modality in a pregnant woman. Why? Because podophyllin as well as imiquimod, both of these are teratogenic. And remember the mechanism of action of the imiquimod is it is a agonist of toll-like receptor 7. Okay, and coming to the symptomatic lesions which are extensive in a pregnant woman, surgical removal is also advocated. Now coming to the genital molluscum contagiosum, so it is caused by MCV, molluscum contagiosum virus, which is a pox virus, and it is transmitted in the adults through the sexual route. And auto inoculation is possible, which is going to produce the similar lesions along the lines of the trauma, and this is what is called as pseudo Koebner's phenomenon. Okay, so we have seen the true Koebner's phenomenon or true Koebner's isomorphic phenomenon. It is seen in the psoriasis, lichen planus and vitiligo. So remember, in the viral infections, that is the viral warts and also molluscum contagiosum, we are going to see what is called as pseudo Koebner's phenomenon due to the auto inoculation of the viral particles. Okay, clinical features of molluscum contagiosum, we are going to see pearly white dome shaped painless lesions which are going to have this central umbilication. Very important point to remember. And predominantly the lesions are going to be seen in the genital area. So coming to the investigation, so it is a clinical diagnosis. Mostly if we have to confirm it, we can do a biopsy where we are going to see the Henderson-Patterson bodies which are intracytoplasmic eosinophilic inclusion bodies. So management, this is a self-limiting condition, but if the treatment is asked for, then we can use the cryotherapy curettage for localized lesions, and topical imiquimod can also be used for the same function. It is an immunomodulator, just like we are using it in the viral warts. So coming to the urethritis, it could be broadly categorized into gonococcal urethritis and non-gonococcal urethritis. Gonococcal, Neisseria gonorrhea is a causative organism. Non-gonococcal, remember, Chlamydia trachomatis, Uroplasma, Mycoplasma and also Trichomonas vaginalis could be the causative agents, but Chlamydia trachomatis is the most common causative organism. So what is the etiological factor? It is an unprotected sexual contact. And clinical features, remember, in the gonococcal urethritis, the patients are going to have very, very severe symptoms in the form of severe dysuria, and frank pus will be coming out per urethra. Whereas in the case of the non-gonococcal urethritis, the patients are going to have, they will be chill, relaxed, not much of constitutional symptoms will be there in the patients, and mucoid or watery discharge may be coming out through the urethra. And coming to the investigation is important. So remember, chlamydia trachomatis, so non-gonococcal urethritis, it is investigation which is going to be NAAT, nucleic acid amplification test. Whereas in the case of the gonococcal urethritis, remember, it is going to be intracellular gram-negative diplococci on gram stain. Very important, asked many times in the INICET examination. So in the management, remember, syndromic treatment is usually given, where we are going to cover both the gonorrhea as well as the chlamydia. And coming to the treatment per se, for targeting gonorrhea, we are going to use ceftriaxone injection, whereas to cover the chlamydia, we are going to use the azithromycin. Okay. Next, coming to the syphilis, the causative organism, I hope all of you know, it is a spirochete, it is Treponema pallidum. And I hope you know the corkscrew motility will be seen in this organism. So spread is through sexual contact, and also it could be due to the blood transfusion, and also there can be vertical transmission during the pregnancy to the fetus. So primary syphilis, what will the clinical features? The patients are going to present with painless, completely painless and button-like indurated ulcer, which is called as a hard chancre, and which is going to be associated with inguinal lymphadenopathy, which is again painless. So coming to the features of the secondary syphilis, in this the patients, so the treponema will be hematogenously spread to the entire body, leading to the lesions all over the body, which will be absolutely asymptomatic, and the lesions could be ranging from macules, papules, patches, plaques. Okay, any kind of lesion can be seen except for vesiculobullous lesions. Okay, so in the mucosa, we can see a lesion which is going to have broad based moist lesion in the mucosa. It is called as condyloma lata, and systemic symptoms will be there. Constitutional symptoms, fever, arthralgia, myalgia, all these symptoms will be there. And also rash over the palms and soles is very, very classical, which is going to be hyperpigmented macules, which are called as palmar syphilids. And there is an important sign associated with this, it is called as Buschke-Ollendorff sign, which is BO sign, where if you press these lesions with the blunt end of a awl pin, the patient is going to wince with the pain. That is, we are eliciting deep dermal tenderness. Okay, very important, Buschke-Ollendorff sign. Next is tertiary syphilis. In this, the patients are going to present with the gummas. They can have CNS manifestations and also CVS manifestations. So congenital syphilis, I hope all of you know this triad, which is Hutchinson's triad, where Hutchinson's teeth will be seen, and there will be sensory neural hearing loss, and there will be interstitial keratitis. So coming to the investigations in the primary syphilis, remember the investigation of choice is going to be the utilization of the dark ground microscopy, whereas in the others we can use VDRL, RPR as a screening, and FTA, FTA-ABS and TPHA for the confirmation of the diagnosis. Coming to the management, remember the treatment is going to be different in different types of syphilis, primary and secondary syphilis. Benzathine penicillin, 2.4 million international units into the buttocks IM is going to be utilized, and neurosyphilis is going to be used in the neurosyphilis. The patients are going to need the aqueous crystalline penicillin, because the benzathine penicillin cannot cross the blood-brain barrier. Okay, and remember there is one more reaction which I hope you might have read this, Jarisch-Herxheimer reaction, where after giving the penicillin, because of the death of the spirochetes, there is going to be a severe constitutional symptoms, and also rash becoming more and more severe in the patient. This is absolutely normal. This is not a contraindication to give a repeat injection of the benzathine penicillin in the later part if it is required in the particular individual. Okay, Jarisch-Herxheimer reaction is the name of the reaction related to the penicillin injection, which is going to produce the rash and the constitutional symptoms. Remember, if a patient is having anaphylaxis after the penicillin injection, then it is absolute contraindication to give penicillin in a later part of the life. We should completely avoid, strictly avoid the penicillin. So now coming to the chancroid. So remember the causative organism is Haemophilus ducreyi. I hope all of you do remember this. Chancroid, Haemophilus ducreyi. So do cry, the patients are going to cry. Why? Because the lesions in the genitalia and also the lesions in the inguinal lymph node, both of them are going to be very, very painful. Okay, and remember, the inguinal lymphadenopathy is going to give rise to the bubo, which is the inguinal lymph node which is consisting of the suppuration, that is a pus. And this is very classical of chancroid, and also it is seen in the case of LGV, lymphogranuloma venereum. Okay, coming to the investigations, remember, in the chancroid we are going to do a gram stain which is going to reveal the diplococci which are present, gram negative diplococci which are present one after the other. We call it as railroad track appearance or school of fish appearance, and the treatment is going to be with the help of azithromycin. So next, coming to the lymphogranuloma venereum, the causative organism for LGV is Chlamydia trachomatis L1, L2, L3. L2 is a more common one. So this is a sexual transmitted disease commonly seen in MSM. So this is going to have 3 stages LGV. So LGV, 3 letters are there. So likewise, it is going to have 3 stages. So remember, this is that genital ulcer disease where the patients may not present with a genital ulcer. So very, very, very transient genital ulcer can be there in the stage 1. In the stage 2, patients are going to present with painful inguinal lymphadenopathy, which is again called as a bubo, and here the appearance is going to give rise to a sign which is called as a groove sign. Coming to the stage 3, here because of the destruction of the lymphatics, there is going to be genital deformities which can be seen, and also there can be rectal stricture or fistula in the case of chronic cases. In investigations, we can do the NAT because chlamydia is an organism, and the treatment is going to be with the doxycycline. Coming to the viral cause of the genital ulcer disease, which is herpes genitalis, where HSV2 is common more when compared to HSV1. Coming to the clinical features, the patients are going to present with grouped painful vesicular lesions which will ultimately rupture and leading to the polycyclic margined ulcers in the genital area, and the patients are also going to have bilateral inguinal lymphadenopathy. Remember, both ulcer as well as the lymphadenopathy are going to be very, very, very painful, and recurrence is usually seen in the herpes infections and because of the decreased immunity in the individuals. So Zhang smear is going to give rise to, it is going to show the multinucleated germ cells. We can also see some acantholytic cells, but multinucleated germ cells is very important term. And coming to the treatment part, of course, it is going to be acyclovir. Remember, students, the examiner has once asked that what is that sexually transmitted disorder? What are those conditions where the partner treatment is not required? And remember, the answer is going to be herpes genitalis, bacterial vaginosis, candidiasis. In these 3 conditions, the partner treatment is not required. Very important previous year question. So next is donovanosis. So what is the causative organism? It is Klebsiella granulomatis. Previously it was called as Kellimatobacter granulomatis. So here the presentation is going to be very peculiar because till now we have seen the patients are presenting with genital ulcer and lymphadenopathy in the inguinal area, but here there will not be any lymphadenopathy in the inguinal area, and this there will be subcutaneous nodules present in a lymph node area. We call them as we call it as a pseudobubo, and the ulcer is going to present as a painless beefy red ulcer. So if you do a GIMSA stain, right stain, we are going to see the closed safety pin appearing Donovan bodies which are present in the macrophages. So these Donovan bodies which are appearing like a closed safety pin which are present in the macrophages, both of them put together, we call them as Pund cells. What is the treatment? We are going to use the azithromycin for the treatment of the Donovanosis. So I hope this video was helpful. So if it was helpful, please do hit that like button, and also if you are having any queries related to this topic or anything in dermatology, please do leave your queries in the comment section, and also please do hit that like button. So if this video was helpful, please do hit that like button definitely. Without hitting that like button, do not leave this video. And do share this video to your friends, and also do discuss among yourselves in the form of group discussion, so that you are going to remember this for long duration. And also do subscribe this YouTube channel if you have not yet subscribed, because this type of awesome content will be given to all the dear students on a regular basis related to dermatology. So we'll meet again in the next video. Till then, happy learning and Sarvam Sri Krishna Arpanam Sarve Jana Sukhino Bhavantu. Bye bye.